This month on the Paramount ND Journal, we sit with Thomas B. Whittle, Medical Director of the Heartland Vein and Vascular Institute. He's a board-certified vascular surgeon with over a decade of experience treating quality patient care. How are you doing today, Dr. Whittle?
Good. Doing well. It's been a day of working in the clinic, and we're still going a little bit, but we're about to wind things down. And doing very well.
Excellent day. As we discussed, we want to cover pelvic congestion syndrome this month and how it correlates to varicose veins. I also want to know, from your perspective, why did you implement this into your workflow, into your business model? And we could just kind of go ahead and start with the what is. What is pelvic congestion syndrome?
Well, pelvic congestion is what occurs when varicose veins affect the pelvic floor in a person. More commonly seen in women, and it usually results from lack of or degeneration of the valves in the ovarian veins in women and testicular veins in men. But it tends to cause some symptoms, which are fullness or achiness or throbbing in the pelvic floor, and can cause a protrusion of pelvic floor varicosities, especially in the perimetrium, which is the tissue between the uterus and the ovary and along the pelvic floor. Some of the most typical symptoms are pain after intercourse for women, or some bladder spasms or rectal spasms where there's a urgency to go to the bathroom. And there can be some other vague symptoms, but they tend to present to our practice with recurrent leg veins, because once these varicose veins in the pelvic floor can no longer escape out of their normal pathways to return up to the heart, they start to leak into the legs and cause an increased tension or protrusion of varicose veins in the inner thigh or the buttock, which extend down the back of the thigh and around, sometimes even below the knee to the ankles. And
is that correlate to how you actually diagnose the syndrome?
It is. It does. When we to officially diagnose it with, clinically we diagnose it by an unusual pattern of varicose veins that appear on the legs, like the inner thigh or the back of the thigh. And that's where the veins appear to be most prominent. And when we ultrasound, they tend to come from higher up, not the usual pattern off of the saphenous veins, but higher up from the floor of the pelvis. And the saphenous veins may have some reflux associated with them at the same time, but many times it's not severe enough to cause the extent of varicose veins that these people tend to present with. So there are some options about diagnosing. Once we clinically suspect the problem, then we can send a female for a transvaginal ultrasound, or we can go take another step and go to a CTV or an MRV, depending on what the radiologists are most familiar with, but both tests tend to pick up the problem for us. And if on that test it shows dilated ovarian veins and clusters of varicosities in the pelvic floor, the perimetrium, then we can offer the patient treatment. If we treat the legs without assessing for that or without addressing that problem, they tend to come right back within a year or two. The veins are still there, and the patients become quite frustrated and often will switch doctors and go to someone else to be treated.
What would you say the role of surgery in the treatment of pelvic congestion syndrome would be?
Well, before endovascular techniques came out, there were surgical roles, and the most prominent role, which didn't happen very often because of the risk with it, were large flank incisions on the side, where the ovarian vein or testicular vein in a man was ligated, about 4 4 separate areas from the pelvis up to the pelvic brim, or the origin of the vessel from the kidney vein. But that's a large surgery to go through, and the hemorrhage risk with that surgery is quite high because these veins are often very tense and thin-walled, and just the minimal amount of trauma causes them to bleed quite profusely. And when these varicose veins occur, it's not in a normal anatomical plane. They occur as nests everywhere, and once you break one of them, it's very difficult to control that vein because it has a source of blood flow from several different directions. And surgically, it becomes quite a nightmare to try to manage that degree of bleeding. And often the patients have multiple blood transfusions, and it's just a major risk for them.
Are there any alternative medicine options or medicine treatments?
There's not. There's been some suggested. The most common suggestion is to suppress the pain and discomfort with estrogens. But the problem with estrogens in a patient with varicose veins is it enhances or increases the risk of thrombophlebitis, or could be deep vein thrombosis in these particular patient population. So it can be dangerous to try to suppress the pain with estrogen as clots can form in these patients. There's some patients will wear compression stockings, and it helps to some degree, and they'll elevate their legs. The stockings that they often wear are the pantyhose type to get some pelvic girdle compression. But again, it's not very effective at alleviating the symptoms for most people.
Well, let me ask you this: the difference between embolization and versus surgery. What would you say in the treatment options would be?
Well, there's the best treatment option that we have available to us today is an endovascular approach, where through a remote site, either the femoral groin site or the neck site, we deliver a catheter down to the ovarian or testicular veins, and through the catheter we can sclerose or inject a sclerosing agent into the pelvic floor varicosities, and that causes them to collapse and scar down. And then on the way out, we essentially ablate the causative vein, which is the ovarian vein in a female or testicular vein in a male, and with a coil embolization. And often this takes maybe anywhere from 2 to 4 coils to cause the vein to collapse and to close down. And then we can address the other side. Often both sides are involved, but not always. In some people, it's just one of the 2 veins that's involved. And 90% of the time, the symptoms are addressed with this procedure, and they're significantly improved over a 6-month period, about 90% of the time with that procedure alone. And unfortunately, the long-term of this procedure has not been worked out, and the studies are out to 5 years, and it's so far at 5 years it's held up and done well. But beyond 5 years, we don't know yet.
What would you say the risk factors are to treatment options?
Well, certainly the lowest risk procedure would be to use the endovascular approach to treat these patients. The medical treatment with estrogen suppression has a significant risk of thrombophlebitis. The surgical treatment of flank incisions and ligation is fraught with risk of bleeding and hemorrhage, which is often life-threatening. And the endovascular treatment, although remote, some of the coiling could potentially cause a pulmonary embolus, but that has been extremely rare complication from that procedure. And because of the length of the veins, the coils escaping from that vein would be almost a remote possibility. So altogether, the safest, quickest, and easiest treatment for these patients, and the most effective, is really the endovascular approach with the coiling and the sclerosant combination.
Very well. And we'll finish with this question. Why did you choose to implement this treatment option into your business model?
Well, these patients are frustrated patients, and we see a number of patients with varicose veins, and many of them are recurrent from having previously been treated. I happen to have endovascular skills and have used those in many various ways, not only in arteries but veins with stenting and embolization of other unwanted vessels in the body. And so it was fairly straightforward for me to incorporate that skill set into treating this set of patients, because already we treated leg veins, and it was just a matter of incorporating these endovascular skills to a different set of patients and successfully closing this source of recurrent pain and varicosities for these mainly women, mainly who've had 3 or more children, but a few times there are men as well involved.
Very well. Any final advice you'd like to throw out there?
Well, I do think that oftentimes pelvic congestion has gotten a bad rap because the endovascular treatment has not been so-called approved, but the evidence is 2A and 2B at the worst, evidence that it is quite effective, and the alternatives are quite poor for this group of people who do suffer more than we think they do. And the patients who have it done, it appears to me, in our practice, are some of the most grateful patients that we have, are quite satisfied, especially because they've been bounced from physician to physician with unsuccessful treatment of their leg veins and their pelvic symptoms too.
On that note, we'll leave it on a positive note, and I really want to appreciate you taking the time to sit with us and discussing this topic. I want to get a lot of information out this month about the syndrome, and there's a lot of growth, a lot of fast growth going on with it, and technology does catch up. So once again, thanks for taking the time to sit with us.
Okay.